Hello guys, hope you're doing great. This is Dr. T speaking from Clinical Medicine with Dr. T. Welcome to this episode. Welcome to the channel if you're watching for the first time. So guys, let's finish hypertension. Let's finish up hypertension. So today we're doing treatment of hypertensive disorders in pregnancy. That's what we're doing today. So we're doing treatment of hypertensive disorders in pregnancy. Okay, so guys, one of the things that we should always be careful about when it comes to answering questions about treatment of hypertensive disorders in pregnancy is that if a consultant or your registrar ask you, how do we manage hypertensive disorders in pregnancy, you can't say antihypertensives or use antihypertensives. It depends on what condition under the PIH umbrella, which condition are you talking about specifically, because the management is specific to the condition or to the umbrella. So there isn't like a straight answer. It depends on the type of PIH it is. Like we spoke yesterday that you have under hypertensive disorders, you've got chronic hypertension, and then under this you've got PIH, and under PIH you've got gestational hypertension, and you've got preeclampsia, and you've got eclampsia, and you also have got preeclampsia with severe features. So the management depends. Where are we in terms of this? Let's talk about chronic hypertension. Like we all know, it's a blood pressure that is high before 20 weeks. So these patients say that ideally before someone falls pregnant, they are supposed to consult that, okay, we want to have a child, and my wife is hypertensive, so we just want advice. What should we do? So ideally they should stop the medication as soon as they are found out they are pregnant. And but it doesn't happen. People, they always come when they're already pregnant. So what do you do with those patients? So what you need to do is, number one, there are so many things that are said about this. There are people who say that, like there are articles that say that you continue with the medication that the patient is on and just remove ACE inhibitors or an ARB if they are taking those two drugs. You remove and they continue with what they are taking. If it's not controlling the blood pressure, you add methyl dopa. The thing is, someone who's on chronic hypertensive treatment, there are so many things. If they're using diuretics, there are people who say that diuretics should not be used because they have got the potential of causing oligohydramnios. They can even drop the blood pressure so much that the placenta becomes hypoperfused, and then we all know what's going to happen to the baby if he's not getting enough oxygen and enough blood. So there's a lot of things. Then there are people who say stop everything and give methyl dopa. But in all of these, even though some people say you can continue and add methyl dopa, but there is one thing that they all agree about. They all agree that no pregnant woman should be on an ACE inhibitor or an ARB. Remember, if you can go back to the TAT that we had, our very first TAT that we had about treatment of hypertension, those are your your drugs that switch off the rest system. So the problem is that it's been proven that ACE inhibitors and ARB, they cause renal abnormalities to the baby, to the growing baby. So that's why we should run away from those. So in an ideal world, you should stop everything and put them on a methyl dopa. If this is not enough, you can add, some people you can add hydralazine, while some say you can just add amlodipine. Remember, this is some say amlodipine, some say from here you can move to amlodipine, some say you can move from methyl dopa to hydralazine. So it depends what guideline are you using. So this is what happens. So the bottom line is that someone who is taking ACE inhibitors, ARBs, and then they fall pregnant, they should be taken away from those and they should be started on a different drug. And the ideal drug for pregnancy, as we all know, the first line drug is methyl dopa. And then if it's not responding, then you can add these drugs. That's chronic hypertension. But okay, let's go there before we get here. Let's talk about the extremes. Let's talk about eclampsia. Let's say our patient now has got eclampsia. How do we manage eclampsia? We all know what eclampsia is. It's a patient who's pregnant, high blood pressures, and is feeding. They might have preeclampsia features, or they might have severe preeclampsia features before they started feeding. So what's the treatment then? With eclampsia, you've got two problems there. You've got two problems. Your first problem is feeding. The patient is having seizures. Number two, you've got high BPs. Perhaps before we can talk about this, let's talk about which group of women should be delivered immediately. A patient that has got eclampsia should be delivered immediately, regardless of the gestational age. A patient who's got severe preeclampsia, please go to part one of this TAT, where we talk about these things, how you differentiate one from the other. So a patient who's got severe preeclampsia should be delivered immediately. A patient who's got HELP should be delivered immediately. A patient who's got preeclampsia, and they are more than 37 weeks. Remember, we want all women to at least to go past 38 weeks, but it's not always possible to do that because of the high blood pressure and the severity of these conditions. So now, but this is the standard. If a patient, regardless of how many weeks they are, if they have these, they should be delivered immediately. Now we're talking about eclampsia. So an eclamptic patient, so you've got two problems here. They are fitting. So it means you must do something for the fitting and do something for the blood pressure. What do we do for the fitting? For the fitting, I don't know why my markers are finishing up. I've just bought them. Anyway. Okay. So a good seizure aborter in pregnancy is magnesium sulfate. How is it given? It's a 4-5-5 rule. 4 means you give 4 grams in 200 mils of normal saline, and you give 5 grams on each buttock. That's your stat dose or your bolus. And then your maintenance is going to be 5 grams. You alternate the buttocks 4 hourly for 24 hours. If you don't want to do that, you can give 1 gram IV hourly for 24 hours. In that, when you alternate the buttocks, you can add lignocaine 2%, 1 ml of lignocaine, just to ease the pain a bit. So that's that. This should take care of the seizures. And when you do this, you must make sure that you monitor for magnesium sulfate toxicity. What are the things that you look? These things they will ask you guys. What are the things that you look for in a patient that you have given magnesium sulfate? You want to make sure that you monitor them. So you need to check to monitor the deep tendon reflexes. You check for urine output. You monitor the urine output. So it means the patient who's fainting should have a catheter, must have a catheter, because you can't do an output monitoring without a catheter. You also check the respiratory rate if they don't develop respiratory depression, or you can put them on sets and monitor their sets. You can put them on a sets machine. So in an event that your magnesium sulfate is contraindicated, or you don't have it at all, or maybe you've got whatever problems but you just can't use it, you can use phenytoin. We know phenytoin is a good seizure aborter in adult non-pregnant patients. If you can't use phenytoin, you can use benzodiazepines. And the most likely drug there is your lorazepam. So let's say your patient developed toxicity, magnesium sulfate toxicity. What do you do? So what you do is, remember, you don't need all these things to appear in your patient before you can diagnose them. As long as one or two appears, then you can diagnose them with magnesium toxicity. So what do you do if you pick up they've got toxicity? You stop or you skip the next dose and you give 10 mils of 10% calcium gluconate. Calcium gluconate. And the way this drug will work, the calcium, the magnesium, remember, magnesium is MgSO4. So what's going to happen is that the calcium will come and bind with the sulfate and disperse the magnesium. So it's going to form calcium sulfate. That's how it prevents them. That's why it prevents, sort of like it deals with the toxicity. It reverses the toxicity. So remember, as you are doing all of this, you are preparing this patient for theater. You have called your anesthetist. You have told the sisters. You have told the sisters that are working in theater that, and the porters are aware that you've got a patient that you want to rush to theater. But you cannot rush a patient to theater who's fitting. So that's what you would do for seizures. But now what do you do for the BP that is high? The BP that is high, you give, and remember, one crucial thing, these patients, I've seen it happen, these patients should not be getting like large volumes of fluid. Like there's no reason why this patient should have a liter of water that is running. Remember, they've not lost fluids, they've not bled, so their intravascular volume is still fine. Remember, BP is equal to cardiac output times peripheral resistance. So we know that if you increase blood volume, you automatically increase preload, and if you increase preload, you increase stroke volume, and when you increase stroke volume, you increase cardiac output. And once any of these, if they go up, blood pressure will go up. So putting large amounts of fluids on these patients, you will worsen the blood pressure. So their fluids should run at 80 mils per hour. This is just under 2 liters in 24 hours. Not unless the patient becomes severely hypertensive for whatever reason, then you can, but you should be very cautious giving these patients fluid. So what you want to give for BP, you want to give Adalat 5 to 10. The standard says if the BP is 160 or 160 over 110, you give Adalat 10 milligrams 20 to 30 minutes, every 20 to 30 minutes up until your blood pressure is controlled. But if you are struggling with that, you can move on to labetalol, which is 20 milligrams. You can start with 20 milligrams IV bolus, and then you can increase 40, and then you can even use you can even give as an infusion. So Normally these two drugs, they do the job in terms of controlling the blood pressure. And then your patient is stable, you rush your patient to theater. So we are done with eclampsia. I don't think I'm forgetting anything. So let's say now your patient does not have eclampsia. So we have spoken about chronic, we have spoken about eclampsia. What do we do for these patients? A patient who's got gestational hypertension, there is no danger there. As long as their blood pressure continues to be controlled, they continue to have normal platelets, normal HB, normal transaminases, they are asymptomatic, there's no headache, there's no dizziness, there's no visual disturbances, you continue with the treatment. And you need to see them in 2 bloods almost every week to make sure that you monitor them very closely. Whenever they come, they should have a dipstick, and you screen them in terms of the questioning, in terms of the symptoms that I've just mentioned. And these ones, if they do well, you can push them to 38 weeks. You can push them to 38 weeks, but you need to monitor them. So you continue with the same medication that controls their blood pressure. What do we do with preeclampsia? And we're just saying that severe preeclampsia, immediate delivery. Now, severe preeclampsia, there's someone who can say, let's take this patient to theater and just open up and take out the baby. And then someone else would say, okay, let's just induce and see if they cannot go into labor within maybe 8 hours. But when you decide to induce them, you will need to monitor them. You will need to monitor their blood pressure, monitor how they are in terms of their signs. If they've got headache, epigastric pain, or right hypochondriac pain, their bloods are fine. So, but some would say, I would